So it's kind of very similar to somebody asking you what's your number. You know, in high school, and college, maybe you asked what your GPA was and what your SAT scores were, and in med school, maybe people asked what your MCAT scores were. But you know, in MitraClip world, people always ask what's your number, and I think it's important to take that number in context. You know, and I'm going to describe for you a little bit of context before I show you the case. And you know, if you look at the Everest 2, which was the original publication, I saw Dr. Feldman walking around. You know, the clips were limited to A2, P2, central, and at most two clips were allowed at that time. And that's important to know. But now if you look at where we've come from there, so this is actually last year where Gaurav presented this data, which showed that this is the U.S. experience now, is that most patients will get 2 clips at most. About a little over 90% of them get 1 or 2 clips. And then still we're less than 10%, and I don't know, maybe Paul can tell us what the 2016 data looks like, but I suspect it's still going to be in the single digits in terms of the number of patients that are getting 3 clips or more. So what is a multi-clip case? You know, what is a complex case? Is it 2 or more? Is it 3 or more? Because it looks like most of us are putting in 1 or 2. Very few patients are getting 3. So 3 really the number where it's considered now you're approaching that multi-clip area? Well, there's no real consensus definition. The general statement is that the more MR you have, the greater the vena contracta, the greater the regurgitant volume, regurgitant fraction, et cetera, the more the clips you will need. And most of the data so far evaluate 1 and 2 clips, and very few give us information on what the data shows at 3 clips or more. This is an important study, I think, which kind of moved us beyond the number of clip story, but more is how much can you reduce the MR, and that's really what you're looking for, is that the more MR you have, the more clips you have, but really what you want to be able to do is reduce MR. The more MR you are able to reduce, the better the outcomes of the patients. This is a small study out of Europe, which showed that if you were here down in the purple, if you were able to reduce your MR by 3 grades, you had a substantial reduction in mortality versus if you were not able to reduce your MR grades at all. So again, it's more MR, more clips are important in the setting of more MR, but again, your goal is to reduce MR, and that's kind of the mindset you have to go in with these cases. So the degree of MR reduction is inversely proportional to mortality. And how do you achieve that? How many clips, and when do you stop placing clips? And there's not so much of a science, and some of it may be an art. So I'll talk to you about this case here. So this is an 83-year-old gentleman. He's actually an English professor down in Central California. So I had a real liking to him. He had a heart murmur for about 10 years. 6 months before we saw him, he developed some symptoms. He had some pulmonary hypertension. His imaging confirmed that he had severe MR. He developed some atrial dysrhythmias. Now, despite medical therapy and despite restoring sinus rhythm, he had some persistent symptoms, and he had progressive decline. Now, given his age, everything that he had some mild cognitive impairment and some renal dysfunction. He was actually considered for transcatheter mitral valve repair. So here's his echo and some echo imaging. So on the top left is the transesophageal bicommissural view, and what you see is there's significant flail and prolapse component, particularly more in the medial posterior side of the leaflet. The bottom left kind of corroborates that in the 3D reconstructions here done by Tom Smith, which again show most of that flail is here in the P3 segment and with some involvement in the P2 segment as well. Now, fortunately for us, the anterior posterior dimension here measured about 5.2 centimeters, so it gave us a lot of room to work with. The flail segments approached about 17 millimeter, so really a substantial flare and obviously reversed pulmonary vein flow. So at our institution, I think most places, what everybody does is when they approach an MR jet, they use what's called a central clip concept. Right? And the central clip concept pretty much says is that I go in and I put a clip right in the center of it, and I look at what the residual jet looks like. If the residual jet is quite substantial on either side, then it's probably going to need to be a 2-clip strategy. So you move that 1 clip over. In this case, they moved it over a little medially, and then they bring the 2nd clip in. On the other hand, if you employ the central clip strategy where you put in 1 clip and the residual jet is asymmetric, then you could probably move your clip over towards the higher jet, the more substantial jet, and get away with 1 clip. And so that's kind of I think whether it's systematic or not, what most people try to do, they try to get in, put 1 clip in, and see what the residual MR is, and kind of go from there. So this is kind of the strategy that we tried to employ. So this is again a 3D reconstruction that Tom did, and you're kind of sitting in the anterior wall of the left atrium, looking back down at the mitral valve. So those are your posterior scallops. Here's your anterior mitral valve leaflet cut away, and there's a medial aspect of your mitral valve. And this outline here kind of corresponds to where that regurgitant jet was coming from. So our original plan is to put a single clip right here in the area of maximum regurgitation. Now you can imagine with maximum flail distance of almost 17 millimeters, we had quite a substantial difficulty. We can actually get our and again, this is MitraClip Classic now. So this case was several years ago. This was not NT. And what we were able to do is we were able to get leaflets in there, but as you began to close the clip arms, the leaflet tips began to sneak out a little bit. So the amount of leaflet tip or leaflet tissue that was actually inside was no more than a few millimeters. So we felt very uncomfortable about leaflet insertion in this particular location. So we changed our procedural approach. What we decided to do is just move it over a little more medially where we could grab tissue and then see if we could zipper it. People have described a zipper technique where you just start off in one commissure and then head towards the center of the valve. So we tried that, and then again we brought in our second clip, and again we still could not grab it, and we moved it over. And this way we thought if you kind of moved it over a little bit more centrally to where most of the regurgitation was coming from, you can help anchor that area. And we put in the third one, and then that resulted in a reduction in the MR jet and helped stabilize those leaflets, and we were able to finally bring in that fourth clip. So this is kind of how we did it. So here's the first clip that went in, the second and third one, and there was quite a substantial regurgitant jet. Again, this is the area of the maximum regurgitation we were starting off with, and the jet kind of came over, hugged the plane of the valve, and then kind of swung backwards. And so finally we brought in the fourth clip and lined it up right in between there. So well, we started off here with severe flail here in the posterior leaflet, P2, P3 involvement. We were left with a neo orifice. By pressure halftime, the patient still had a valve area of about 3.5, 3.3 to 3.5. We had 4+ MR to start off with, and this was the final result down here in the bottom center. Reverse pulmonary veins upright at the end. VU waves, which peaked at 33. Down to 15, and then we were left with a mean gradient of about 1.8 at the end of the case. And again, I think a lot of this is due to the fact that the patient himself had a pretty big working mitral valve to begin with. So again, in context, what is your number? How many clips have you placed? I think it really depends on a lot of information. I think more than the number of clips, it's really the amount of MR reduction that you're trying to achieve is far more important. You have to balance that with the gradient, the complexion, the feasibility, and the patient in front of you. We did a 99-year-old lady, and in her case, you put one clip, it's a MR reduction is down to 1 to 2+, and she feels fantastic. Versus you take a younger 60, 70-year-old, you want to try to have what Francesco Mazzano calls a surgical result. You're trying to get it down as low as possible. So that's kind of the balance that you have to create when you think about what your number is. So, all right, thank you.
I really like the Italian flair there.
Don't tell Francesco Mazzano I did that, by the way, please.
Fantastic. No, so I think the zip and clip, as you demonstrated very elegantly, it's one of those techniques that you have to have a bit of faith. And fortunately, if you pick the right patient, these are patients who have no option, and you start zipping and hope it works. Because a lot of times the first clip you place, or even the first two, may not affect the MR. Mm-hmm. And the idea is it's supposed to make the one clip go in where you will affect the MR, but it does take a leap of faith. Yeah. So what's your number? Yeah.
What's that? We've done 5 in one patient, but there was 2 separate procedures. But at one particular time, 4. So
4 at one. So he's done 4 at one time or 5 at 2 times. You can take his number as what it is.
Well, so he's giving you something for next year, Paul.
Questions from the audience?
All right. Cool.
Great
Thank
case.
you.